So the idea then was to produce much better short and long-term outcomes for children who are at risk of social exclusion. So these are the ways the service is provided: home visiting, community clinics, mental health and maternal and paternal mental health is assessed, women's health centre appointments. So what this means is we look at the potential for child abuse, which includes sexual abuse, physical abuse, emotional abuse, and we also look for children's centres and to be run out of health centres and from churches actually, and other areas in the community. We work together with doctors, we work with social workers, the police, teachers, dentists, midwives and mental health practitioners within our health partners amongst many others. We also work across boundaries from time to time. But still, and I have to say, the recent safeguarding information says that most of our safeguarding happens, most of the problems happen with children, most abuse and deaths happen amongst children because the professionals don't communicate, and that's not because they don't want to, it's difficult, but that's been a situation that's been ongoing for several years now. So the other things that we look for is to support breastfeeding, to identify learning disability in children, so we look at autism, attention deficit disorder and those kind of problems. We also identify tongue tie and other minor health problems at that point. So in addition to this, we promote health education and we look at immunisation and vaccination and help people to get their core immunisations. This isn't mandatory in the UK. There is a choice. Parents don't have to have their children immunised. In some countries, for example in the US, children can't enter school unless they've been immunised, and I think that's the same in France as well. In the UK there is a choice. So here I am scooting ahead of my overhead, as I say, immunisations, health promotion. Alcohol and substance misuse is also very big in the families that we manage. Complex issues are very common. We try to work on building community projects in a needs-assessed way. So there are projects going on in dental health. We've identified some areas where children's dental health has been very poor and they've had full tooth extractions before the age of 4 years old. We also prescribe medicines for minor illnesses. So we prescribe for eczema, for oral candidiasis, which is thrush. We prescribe for nappy rash, and we give lots of advice around medicines and medicines consumption. And we've been fulfilling that role as health visitors since 2000. And we now, as you're probably aware, have other nurses that prescribe from a lot wider formulary for things like diabetes and heart disease. So the call for action to double these numbers happened in Department of Health 2011. And as a result of that, the impact on us as a university was that our numbers moved from about 40 students undertaking this postgraduate programme to 140 students. And at the time I think there were 2 lecturers providing that, and it's 50% practice, 50% university. So they were running around. The expression is like headless chickens, trying to see all the students in practice as well. But we quickly recruited, and at that point I actually moved from the practice setting back into education where I'd been before. We moved on, and we have so far, as I say, nearly reached our target. The last big cohort is 130, and we have 2 more cohorts of 40 which are moving through as we speak. And our university will hopefully complete by March, and then there'll be a normal training programme to keep the numbers of health visitors at a better level. So the other problem that in practice, there were few practice teachers. Now practice teachers we have mentors in the UK with nurses, and then the next level up are practice teachers. And we used to work with health visitors on a 1-to-1 ratio in the practice setting. And we had to devise different models of working to be able to cope with these extra students. So one practice teacher might have working with them 3 mentors, and they might have 3 students. So the mentor would be 1 mentor per student. However, in some places, and for example Norfolk, which is the next county up from that where I live, they had something like 1 practice teacher managing at times about 11 or 12 student health visitors, and they were literally driving around the country. And to give you some idea, I think the east of Anglia is pretty similar to the size of Sri Lanka. So lots of miles on the car. So we also had to upskill the registered health visitors, because what had happened over the years, we had very few students in the practice setting, and people were so busy, they become demotivated and they become tired, and they weren't being given the continuing professional education that they needed. So they were quite anxious about having the students in the practice setting, because they felt themselves that maybe they weren't as evidence-based as they should be. So not only did we have to train the students, we had to train the health visitors. We upgraded some of the health visitors to mentors and upgraded some of the mentors to practice teachers. So we had lots of different educational provisions going on within the university. So we had large numbers. There were less time for individual tutorials with students, although we still did give them. We made good use of emails. We also did lots of discussion boards on the virtual learning environment. And we had small group work, because you can imagine in a group this size, it's more difficult to learn than it is in groups of 10 or 12. So we put on additional workshops to ensure that each student had their chance to have their say. It was difficult to know all the students well. So as a result of that, we divided the group up between the 5 of us that were delivering the programme, and we all got to know our own students very well indeed, and that was done geographically. So we would go out into the practice setting to see our students too. So this depicts our diverse students, and we do actually have a very diverse range of students. We don't have too many males, but they're growing in number. But we do have people that have chosen to come into health visiting from other positions. So we have what I call mature students. So we've had students in their 60s actually, and we've had students that have just finished their initial registration as a nurse. And managing these people diplomatically and dynamically without having too much debate, and as your chair might know, health visitors are quite assertive people, and you get too many of us in one room, and we do have quite heated discussions. So it can be quite an interesting debating classroom. So the other things that we brought in were regular link visits. That's where the university lecturer goes out into the practice area and manages a consultation with the student and with the mentor. We have very transparent, open relationships, and we try to support the mentor to support the student on those visits. And those are done at least once a trimester. It's a whole year training course. And sometimes we will go out more often if there are problems. The working environments are very diverse. The clinic areas, some are very overcrowded. Although the government paid to fund a good increase in students, they didn't increase the size of the venues. What they did give them was some technology. So some health visitors had laptops, and they were expected to work in the practice setting, in the home with a laptop. And that's actually quite difficult if you're having a one-to-one conversation with someone. But they've tried to make it easier, but then you lose the contact with colleagues. So that is a problem. And the university teaching, we went from a nice sized group of about 40 to a lecture theatre with about 130. So obviously you have to change your style. And certainly in the UK we like to do more small group work, interactive sessions, and that kind of thing. And we had to go back to a degree to didactic work. But again, we made good use of the virtual learning environment and had lots of discussion boards, quizzes and workbooks, and tried to create more interesting ways of working with the students. So the student practice teachers, I identified, having been a practice teacher and moved into the academic setting, that there was actually a huge gap in the support for these student practice teachers. They undertake a postgraduate postgraduate certificate in medical education. So it's a mixed group. They have their education with doctors, with physios, with other allied health professionals, but practice teachers with the SCIFNs, as we call them, are the only ones that actually require a nomination on the register as well. So they have to be assessed in practice delivering their teaching. And at that time there wasn't really any support for them, because prior to this there was a small number of practice teachers. So that's a gap that I worked with the team who provided the PG MedEd to provide, and we validated some robust documentation which it required 2 weekly supervision from a qualified practice teacher to enable them to feel much better supported, and that goes on with the preceptorship documentation which was created to support them beyond their qualification. So the student experience was measured, and in actual fact the students said they felt they got a very rich experience, because we worried that it was too fragmented. They were having too many people involved in their training. But their experience, that wasn't the case, and some research by Devlin and Mitchison actually supported that, which was carried out in 2014. It's still early days, and we do need to measure that further. And we need to measure what difference they've made in the practice setting to see if indeed our children are growing up healthier, and if we're identifying the issues that we should be. We're certainly identifying more need, because the more health visitors we have, the busier they seem to be. We also, through the cycle of Anglia Ruskin and practice, we have lots of evaluations. So the students' evaluation, both their mentors and teachers, and the mentors and teachers evaluate them, and actually they get to see their own evaluation forms. The cycle is complete. So, any questions? But I'm not going to do questions yet.
Thank you very much.